I'm Jonathan Friedberg, chair of the SWOG Lymphoma Committee, and I'm the director of the Wilmot Cancer Institute in Rochester, New York. And I'm going to speak just a bit about the treatment of older patients with Hodgkin lymphoma. I think we all recognize that Hodgkin lymphoma is a disease that is highly curable with standard treatment. And in fact, the vast majority of patients who present with Hodgkin lymphoma today are cured. The one group of patients where outcomes are significantly inferior are older patients. And this can be defined in several ways, but if you look at the 20% or so of patients with Hodgkin lymphoma who present over age 60, those patients have a markedly inferior outcome. And in fact, as patients get to be 70 and older, the survival curves look much more like solid tumor survival curves than traditional Hodgkin lymphoma. The reasons for this are likely multifactorial. Certainly, older patients have a harder time tolerating treatments. And in fact, the treatment-related mortality of standard therapy for older patients is quite high in some series. But in addition to that, there may be genetic features or other molecular features to the cancer itself that confers resistance to our treatment, similar to what we see with leukemia, where patients who are older have more high-risk biological leukemia. The approach to patients who are older with Hodgkin lymphoma, first, I think it's important to recognize that we shouldn't use age as a strict cutoff. There's certainly no big difference between a 59-year-old and a 61-year-old. And in fact, the field is getting away from biologic or chronologic age to really a measure of fitness of the patient. And there are tools now that have been validated in other lymphomas and certainly in solid tumors, ranging from formal geriatric assessments to simpler tools that are able to classify patients into categories such as fit, unfit, and frail. These tools rely on measuring comorbidities and functional status, often that can be assessed quickly in the office with a survey or observation of patients. And once you undergo this type of assessment, then you can start to explore what the literature tells us about outcomes of patients. First, for standard treatment, which in most cases includes combination chemotherapy, sometimes with radiation therapy. In Hodgkin lymphoma, the number of patients that have been treated that way who are over the age of 60 in most studies are quite limited. For example, in the recently published Echelon-1 trial, which demonstrated an overall survival benefit to brentuximab vedotin over standard ABVD in patients with advanced stage Hodgkin lymphoma, less than 10% of the patients enrolled on that trial were over the age of 60, and the benefit of brentuximab in that group was less clear. The overall outcome was also inferior. And in a previous United States trial through the National Clinical Trials Network that evaluated either ABVD or Stanford 5, another combination chemotherapy, the outcomes of patients over the age of 60 were quite inferior, with substantial treatment-related morbidity and mortality due in large part to the bleomycin exposure. So more recent attempts at treating older patients have looked at getting away from combination chemotherapy to look at doublets or even single agent treatment using novel agents. So I was part of a group that looked at brentuximab vedotin as a single agent, and then doublets including dacarbazine or bendamustine or nivolumab. And in each of those cohorts, we showed a group of patients that had very high response rates who were a median age of over 70. However, it was only the nivolumab group that really seemed to experience prolonged progression-free survival, suggesting that a subset of patients may even be cured with this type of an approach. And this type of an approach may be particularly beneficial for the unfit or frail patient who could not tolerate the standard chemotherapy well. I think what is becoming more clear to international investigators is the importance of focusing on this group as a unique subset of patients. And we probably can't enroll the majority of these patients on our standard trials that are looking at aggressive treatments such as ABVD or AVD nivolumab, AVD brentuximab, or the German Bayakop regimens. So we need specific clinical trials, ideally randomized in an organized way to understand how best to treat these patients. And these trials have to include appropriate assessments of fitness, whether it's a formal geriatric assessment or using other surrogate tools. With that, I think we're going to be able to see improved outcome. And my final comment would be that the checkpoint inhibitors may offer a particular great opportunity for these patients. Certainly in many other solid tumors, we've learned that checkpoint inhibitors can be safely administered to older patients. And in fact, some of the autoimmune toxicities may be less in older patients, due in part to the senescent immune system. But early studies are suggesting very high response rates in Hodgkin lymphoma in older patients with checkpoint blockade. And I anticipate that any new treatment for these older patients would either include checkpoint blockade or disproportionately rely on checkpoint blockade as a component of the treatment. Thank you for your attention, and we look forward to improvement in this area moving forward.